Have you done tension-free vaginal tapes for your patients with SUI? It can be anything, either obturator approach or retropubic approach. If you have done this, today the article which I am going to discuss with you and the related discussion is going to be very interesting for you all. And for those who have not done it but are planning to do it in future, it is for them also. I think a very important paper which has been published in International Urogynecology Journal, August issue. So, I'll take you a few years back. It was the year 2017 or 2018. I was attending a conference and I was in one OT with my team. I was operating there, and there was another OT which was running in parallel. And the surgery what that other team was doing there was TOT or TVTO, that means tension-free vaginal tape by obturator approach for a patient who had SUI. After the procedure was over, there was a question from the audience, and in the other OT we had the luxury to watch both the screens there because that time we were not operating. That was a break time for my team. But we were not in the position to discuss anything. We were like silent observers there. So this one young girl from the audience asked this question to the surgeon who had operated and finished the surgery just now. She asked that what happens when you put this tape below the urethra and when you are trying to take it out from the obturator canal, if the tape gets twisted, what should we do? What should we do? The answer given by the surgeon was, it should not twist, it should lie flat like a tape throughout the course, and if by mistake or by chance, if it gets twisted, turned or gets rotated, then you have to remove it and reinsert it. Now, for those who have been doing this procedure, tell me, what is your opinion? For me, it was not the correct answer, because whenever you put a flat thing from a spacious place to a thin tunnel, there is more chance than not that it will get twisted, turned or rotated when entering that canal or when exiting that canal. And this is what happens to me every time I do surgery. So the aim is just to keep it flat when it is below the mid-urethra. And when you take it out, invariably, in 99% of cases, if not 100, it gets rotated or turned or twisted at some point or the other. According to me, you don't need to do anything about this. It has been a long time since that discussion came on, but somewhere in the corner of my mind, this question and this discussion remained, though I kept on teaching, which was my philosophy. But recently, when I came across this article, I thought, yes, it is not as clear to everybody as black and white. Maybe this question is there in people's mind. That's why people have tried to create this evidence and tried to find out the answer for that. So it was very interesting for me, and I wanted to read that. And after reading this, I want to read it to you too. So the question here is, when you put the tape in any kind of tension-free vaginal tape surgery for patients with SUI, when you are putting this tape, what happens, or what should I do, or what should you do if the tape by mistake or by chance gets twisted in its course? So let's try to find out the answer for this interesting question. Once again, the article comes from our favorite journal, International Urogynecology Journal, and the issue is the latest one, August 2022. This is an original article, and the study has been given an interesting title, Twisting of Transobturator Mid-Urethral Slings. Does it matter? Let's start with the abstract. In short, the authors or investigators here are trying to assess whether rotation or twisting of mid-urethral slings, and specifically the TOTs, is it associated with de novo chronic pain or voiding dysfunction in women who have undergone this procedure. It was a retrospective study, and the tape which they have studied is Monarch TOT. It is a company name. The study was conducted in a single tertiary hospital, and the duration from which these patients were taken was from 2005 to 2016. That means a total of 12 years period. All these women who were included in the study were operated. The number of total women who were operated in this 12-year period with Monarch TOT was 215. They included all the patients initially. However, 52, that is 24%, had to be excluded for some reason or the other, and the final analysis thus was performed in 163 women. Median follow-up was 17 months, which is around 1.5 years. What they found and concluded was interesting. De novo chronic pain was associated with lower BMI and vaginal sling exposure, but not with sling rotation. Sling rotation was not found to be associated with voiding dysfunction either. Now, the final conclusion was very interesting, that TOTs rotate considerably throughout their course. The degree of twisting or rotation and its direction was not found to be associated with de novo postoperative chronic pain or voiding dysfunction. For me, it was very reassuring and relaxing, and I felt like reading this entire paper, what they say in this. Starting with the introduction, they have given a little bit history about how it all started. Let me read it for you. The introduction of retropubic midurethral slings at the end of last century has revolutionized the field of urogynecology. Correct. The procedure is short, simple, and highly effective in the treatment of SUI. Furthermore, it has low complication rate. The first tape which was used the retropubic space to put the sling. However, soon people realized that it had some complications, which were the dreaded ones, like bladder perforation and vascular injury in the retropubic space. Thus came in picture the other alternative, which is TOT or tension-free obturator tape or transobturator tape. TOT is associated with higher rates of postoperative pain, groin area, and de novo dyspareunia. That was realized later. However, during the per-op period, it is associated with less injuries to surrounding structures because of its alternate pathway. It has been suggested that de novo chronic pain after TOT might be due to faulty sling placement and twisting of the implants in its course from one obturator foramen to the other. However, this is not a proven thing. This is just a hypothesis. Yes, this later hypothesis exactly has not been objectively studied till date. That's what the authors write. So the primary outcome was to describe the sonographic spatial appearance of TOT in the study, while the secondary outcome was to test its association with, as we have already discussed, de novo postoperative pain and voiding dysfunction. The null hypothesis was that TOT twisting is not associated with either chronic pain or voiding dysfunctions. Moving on to material and methods, it was a retrospective study and it was a pilot study. If you don't know, pilot studies are small level studies to see the feasibility of a bigger study. So usually the sample size is small in these kind of studies, and they are just the background to do further studies in the same subject. The time span was 12 years when all women during June 2005 to May 2016, those who were operated with Monarch TOT were followed up. The surgical procedure was performed in a single tertiary teaching unit. However, the very good thing about this study is that surgery was performed by over 2 dozen trainees, avoiding any bias related to the surgical skills and experience. During the follow up, patients were asked about any de novo chronic pain, groin pain, or dyspareunia, and also about the voiding dysfunctions. After that, the routine investigations and tests were done, and the exclusive thing for this paper was the 4-dimensional pelvic floor ultrasound was performed for all these women. All the ultrasounds were done in a single machine, which is Voluson E8 system, and the data was analyzed by a single investigator who was blinded against all clinical data. I think this is very important, that if you know little history, you tend to get biased while interpreting the ultrasound results. All of us know this. So very good thing about this study was that the person who was interpreting all the ultrasound data was blinded to all the clinical information about these women. Here, I'm not going into the details of how the ultrasound was performed, the technicalities of the same, and how the images were rendered and interpreted. Only one thing in the upper panel, the central image, you can see to see how finally the image came up to show the tape position or placement. If you want, if you are a radiologist or if you are doing the ultrasound regularly, or even if you want to do similar kind of study, you can just search this paper in the internet, or if you don't have the access, you can ask me, I'll send you the entire paper. You can go through the details and find out. But we are not going into the minutiae of the procedure and the technicalities of assessing the angles and rotation. We'll just focus on their results and interpretations. So during the study period, as we have already discussed, there were 215 patients who underwent Monarch sling insertion. After exclusion, 163 women were included for final analysis. The mean age of these women was 57 years and BMI was 29.4. The last follow-up was performed at a median interval of around 17 months, which is around 1.5 years. In this cohort, in this duration, 11 patients described de novo dyspareunia and 4 described de novo chronic pelvic or vaginal pain, which made it a total of 9% of patients reporting any postoperative de novo chronic pain. De novo voiding dysfunction was noted in 34 women, which made it 27.4%, but none of these women required further intervention. The management was conservative. The subjective success rate for cure of SUI was 84%, that is, 136 out of 162 patients were completely cured of stress urinary incontinence. Very interestingly, this paper has only one table that summarizes all the major findings. First, it compares both the groups. So the two groups are patients without chronic pelvic pain, those were 148 in number. However, patients with chronic pelvic pain or dyspareunia, which were 15 in number. So what they saw that both the groups were comparable in all their demographic features as well as the follow-up. Then they also tried to find out the relationship of the ultrasound findings of their tape twisting and turning with whether they had chronic pelvic pain or they were in the category of no chronic pelvic pain. Please focus on the last three lines of this table. Midline sling angle, same in both the categories. Sum of absolute sling twisting, not significantly different. Corkscrew sling rotation, again similar in both the groups. I am now reading the key results in the words of the authors. In this retrospective pilot study, we have used sonographic imaging to demonstrate that TOTs rotate substantially in their path from side to side in the pelvis. That's normal. This rotation seems to be a normal phenomenon with no apparent association with morbidities such as chronic pelvic pain, dyspareunia, or voiding dysfunction. Are you happy? If we compare it with other studies, the other studies have just investigated the relationship of the tape in relation to the urethra and the bladder neck. This study, in contrast, focuses on sonographic sling appearance as the implant courses from the midline laterally to the obturator foramen on both the sides. The earlier studies mostly focused in the success rate of treatment of SUI, and some also studied the voiding dysfunction. However, this particular study also tried to find an association of sink placement with the less research outcome, that is de novo postoperative pain in the form of groin pain and also dyspareunia. One thing which has not come to my mind before and I have not followed up in my patient seems interesting here about the post-operative effect of obesity on chronic pelvic pain. They say if the patient is obese or the BMI is high, there is less risk of chronic post-operative pain. Maybe because of the fat in between helps to decrease the irritation of the tape to the tissues or to the neurovascular bundles. I found it very interesting. So, what are the strengths and limitations of the study? I'm not going into the limitations, but because they are all the same retrospective studies, small sample size, etc. and etc. However, I'll read the strengths to you. A major strength of the study is that post-processing of ultrasound volumes were performed while blinded against all clinical data by a non-surgeon co-author, virtually removing any possibility of assessment bias. Very important. Another strength is that multiple surgeons perform the procedure, which makes our results more generally applicable. And bravo, we have already appreciated both the strengths of the study before coming to this section. And finally, we reach the conclusion given by the authors. I will read it word by word to you. In this era of mesh controversy, it seems prudent to gain as much information as possible from multiple diagnostic modalities so that treatments and health policies can be based on empirical data rather than speculations or anecdotal information. The authors emphasize here that our results disagree with the anecdotal suggestions that twisting of the implanted TOT might promote chronic complications of pain and voiding dysfunction. Moreover, it seems that TOT twisting is a rather common phenomenon. So I'm very happy to read this and understand this thing, and I want to pass this message on to all of you and tell you to pass it on to other friends or colleagues who are still thinking that twisting has a negative impact on your results post surgery. Thank you.